Hey guys, Dr. Haverland here. I am going to let some people enter the room and we will get started shortly. Hey guys, for those of you that just joined, I'm Dr. Haverland. I'm just letting a few more people enter for the next few minutes and then we'll get started shortly. Hey guys, Dr. Haverland here. I'm just letting a few more people join and then we will get started with our webinar. Hey guys, we're just waiting for a few more people to join and then we will get started with our webinar. Thanks for being with me this Wednesday. Just 1 or 2 more minutes. Okay, guys, let's get started. I am Dr. Rachael Haverland with Endometriosis Center of Excellence. Thank you for joining me on this webinar. There will be a few more people joining us as we go. But essentially for the next hour, hour and a half, we'll be talking about what I am most passionate about in endometriosis. And today specifically, when your tests come back normal, why do you still feel like this? So kind of talking through kind of the ups and downs of endometriosis, why the diagnosis can be really difficult. But this should be interactive. So if you have questions, please use the group chat. I would love to be interactive with you. Essentially, this is me talking to a computer for the next hour. So I will go to the chat intermittently and answer some questions, specific questions that you may have. Also in the chat, there's going to be a calendar put in the chat that you can click the link and make an appointment with my office manager. Her name is Cyrus. And at this time, at this calendar invite, you can talk to her about scheduling a visit. You can go over your insurance and those types of things, and ask her questions about the practice and scheduling, and then she will get you put on my schedule. I will warn you right now, we are a little booked out, but we're working on adding some more space. Also, some exciting news that I'm not able to share exactly all of the information yet, but we are going to be bringing on another surgeon to Endometriosis Center of Excellence starting in the new year. So that is really something exciting to look forward to for the practice. So once that gets started, we'll be able to get more patients in and more visits, so you won't have to wait so long to be seen and then ultimately be treated. So I'm looking forward to that. So again, thank you guys for joining me today. I'm Dr. Rachael Haverland with Endometriosis Center of Excellence. So today in this webinar, your test came back normal. So why do you still feel like this? Texas women, I want to start with something you probably experienced. Your tests come back normal. Your ultrasound, clear. Your blood work, fine. And you were told, well, everything looks good. But let me ask you something honestly. If everything is normal, why don't you feel normal? Because your body is still dealing with pain, bloating, fatigue, and no one can explain why. For many women, this is where things start to break down. Because of what most women are never told is that endometriosis often doesn't show up on standard imaging. So instead of getting answers, you're told everything is fine. And today we're going to unpack why that happens and what your body may be actually trying to tell you. So here's the problem. We rely heavily on tests to confirm what's happening, but not everything shows up on the tests. So when the test results come back as normal, sometimes your symptoms get dismissed. You're told, well, there's nothing wrong. Everything looks fine. But your body says otherwise. This is what I call the test blind spot. And it's one of the biggest reasons conditions like endometriosis go unrecognized early, because nothing is there. And it's not because nothing is there, but it's because it's not being detected the way that people expect. And I think that this is a very important point. So this test blind spot is unfortunately significantly negatively affects the diagnosis for endometriosis, and why so many women go so long without having a diagnosis. So I'm Dr. Rachael Haverland. I am a board certified gynecologic surgeon and women's health specialist. And I want to be very clear about something. Most of the women I work with were told everything was normal. Their tests didn't show anything, but their symptoms are very real. And we take a deeper look. What we often find are patterns consistent with endometriosis that were never clearly explained before. So I am not here to label you, but I am here to help you understand what may have been missed. So I think that this is extremely important process with endometriosis, because a lot of women are kind of gaslighted, or they're not taken seriously, especially young women in general, told that maybe it's anxiety or nervousness, or, well, your tests look fine, or your ultrasound looks good, so we don't know what's going on. But a lot of times they kind of get pushed down the road, and instead of getting clear answers. And so I'm wanting to talk about that a little bit today. And go through some of the more credible testing options for you. So the secret number one is that normal tests do not equal normal body. So there's a belief that if my tests are normal, I must be fine. But the truth is, normal results do not always mean that nothing is wrong. Because endometriosis doesn't always show on ultrasounds or MRI. The blood work for endometriosis is contradictory. There's a study in the UK that may show some evidence that a blood test may be able to help diagnose endometriosis, but it's also put on by the pharma company. And so is it a little bit biased? It's not available in the United States as of now, but we don't have good testing. So symptoms like pain, bloating, fatigue, they can still be present even when your tests look normal. And so, this is one thing that I talk about, you know, all day long. We have to listen to our patients. Endometriosis is a diagnosis of history. We have to listen to the symptoms and understand where patients are coming from. Most of the time, endometriosis is not seen on imaging, even with the best ultrasonographer, even with endometriosis mapping, with ultrasound, even with rectal contrast, vaginal contrast, MRI. Until endometriosis is more advanced stage 3 or stage 4, and even some stage 3 is not seen on imaging. Most of the time, endometriosis cannot be identified or identified clearly. And most of my patients come in stage 1, 2, some stage 3. Of course, there's a subset that are stage 4, but I will say that a lot of my patients have had these experiences. They were told, my ultrasound is normal, so there must not be anything wrong, dismissed from the emergency room. But until endometriosis is more advanced with deep infiltrating disease, rectal disease, or an endometrioma, most of the time we don't see it on imaging. And so ways that we can identify this mostly is history. I just listen to my patients. If they're telling me they, have had painful periods since they were a young girl, the pain is getting worse. She's now having pain between periods. Now it's affecting her bowel. Now it's affecting her bladder. Now she's having painful intercourse. All of these symptoms are very classic for endometriosis. And what's interesting is that even though all I do is endometriosis, I'm still surprised by endometriosis. Endometriosis does not follow the rules. I have patients come in frequently and their only symptom is fertility, for example. They don't have a lot of the other classic symptoms, or maybe they do, they just haven't really realized that they're not normal. Some people just have painful intercourse, for example. Some people just have bloating. That is their main symptom. And so every patient is different. So really listening to their history will help you get to the root cause. And once you listen to their symptoms, most of the time, this is endometriosis until proven otherwise. Endometriosis is actually a very common disease. It affects 1 in 10 women, and it's vastly underdiagnosed because of one of these reasons is because we don't see it on imaging. So women are told, we don't know why you're having pain, or we don't know why you're having these symptoms. But most of the time, this is endometriosis. And when your symptoms fit endometriosis, even if you have negative imaging and negative blood work and a negative workup, you still should be evaluated for endometriosis surgically, because that is the gold standard. The gold standard is laparoscopy with endometriosis excision, removing the root cause so that the endometriosis doesn't continue to spread and continue to get worse. So this belief that normal tests does not equal normal body, I think it's very important. That is the first thing I want to talk about. So if your tests are normal, does not mean that you're fine, because most of the time endometriosis does not show up on imaging until it is very advanced. So the next thing I want to talk about after normal tests do not equal normal body is that symptoms are data. And here's what more and more people realize. Your symptoms are the data. Patterns matter. Ask yourself, do your symptoms repeat every cycle? Are they affecting your daily life? Do they feel more intense than they should? If yes, that matters, because for many women, these patterns are where endometriosis shows up first, even when tests don't confirm it. So certain types of symptoms, bloating. I saw somebody mention on the chat. Bloating is getting worse, especially as I'm getting older. I'm 49. I'm feeling it, more frequently. Endometriosis very much can cause bloating. Essentially, this is inflammation of the pelvis. This can affect the uterus. Endometriosis can cause this. It can be from the bowel. So really, it's multifactorial. But some women come in and they're like, I look pregnant. People keep, congratulating me in the grocery store, and I get really embarrassed because I'm not pregnant. My abdomen changes drastically throughout the day. In the morning, it's flat. In the afternoon, it's protuberant, or it changes every other day. I have pants that I can wear when I'm more bloated. I have other pants that I can wear when I'm not bloated, and that's not normal. There's something going on, something that's causing this inflammation to cause this expansion. Um, and endometriosis, we'll talk about this in a little bit, but it's very much a whole body disease. Endometriosis affects us in many different ways. It can affect our immune system. It can affect fatigue. It can affect our bowels. Women with endometriosis tend to have more food sensitivities. It can affect your bladder. So it is not just a disease of the pelvis and the reproductive organs. It's very much of a whole body inflammatory disease. So when you're feeling these symptoms, it's really something that you need to remember. It's a data point that you need to write down, because your symptoms are the data, and the patterns matter. And so as you're experiencing these symptoms, if you can find these patterns, it can be really beneficial. Also, when you come in to talk to your doctor about what things are changing and how your life is being affected. Are they repeating every cycle? How is it affecting your daily life? Are you not wanting to go out to dinner with your friends or go exercise, or take that job promotion because you're not sure that you can tolerate it? And then, are your symptoms getting more intense? Are they more intense than they should? I'm going to go to the chat and answer some questions. Again, you will see a link in the chat. This calendar invite is to meet with my office manager. Her name is Cyrus. And during that time, you will be able to have a meeting with her that's scheduled, so she can go over your insurance, decide if you want to schedule a visit. Like I mentioned, I am booked out pretty far, but I'm working on that. Hopefully, our new surgeon will join us in January, and that will be able to help us cut back on some of the wait time so that my patients can get started earlier. All right. So one of the go into the chat for a little bit, and then I'll go back to the webinar. So this person asks, is endometriosis hereditary? Because I think my daughter has the same thing. Endometriosis can be hereditary, and it doesn't mean it will, but with a first-degree relative like a mom, your risk of endometriosis increases 6 times, not 6%, but 6 times. So endometriosis already affects 1 in 10 women. With a first-degree relative having endometriosis, your risk of having endometriosis does increase pretty significantly, especially if she's symptomatic. Your biggest risk factor is if you have a sibling. If you have a sister with endometriosis, that's going to increase your risk pretty significantly. And so we don't know everything about endometriosis. Even in 2026, we are learning so much. We don't, we have some good ideas about the evolution of endometriosis, how it starts, but it's difficult to know why some patients with endometriosis tend to be more symptomatic, why some patients have endometriosis that's more aggressive, why 18-year-olds have stage 4 disease, but a woman may wait until her 40s and still it just stays at stage 1 or stage 2. Why do some endometriosis grow more rapidly? Is this related to an immune response? Is this related to the type of endometriosis? And a lot of these things we don't know. Women with a genetic predisposition, like a family member, their endometriosis does tend to be more aggressive. And again, we don't really know why. But women with a family history, like a mother or especially a sister, they tend to have symptoms earlier. And when it's caught, endometriosis tends to be more advanced, like a higher stage endometriosis. And so it can be genetic predisposition. And so the important thing is just to listen to her, listen to her symptoms, and make sure she goes in and gets evaluated early for options. Okay. Okay. This question says, how do you get a doctor to do a laparoscopy if it didn't show up on the scans? Well, doctors that understand endometriosis also understand that most of the time it's not seen on imaging. It's very important, however, if you're going to have endometriosis surgery, that is done correctly. You need to make sure that your doctor is doing excision, which means essentially removing the disease. If they go in and just burn a few spots, they don't take a sample to send to pathology, unfortunately, the surgery is really not beneficial. I'm a little bit more aggressive, in treating my endometriosis, but this is all I do. So identify the endometriosis, make sure that we're getting really wide margins, around the endometriosis so that there's a better chance it doesn't recur. Some patients, the endometriosis also is more subtle. In young women and in older women, endometriosis tends to be more atypical in appearance, meaning it's like clear blisters, red spots, brown spots, sometimes can just look like scar tissue, but this is like early endometriosis. Classic endometriosis is what we were taught in training, big black powder burn spots that you can see. But it's important to, one, be able to identify the endometriosis in all the locations of the abdomen and pelvis, and then two, be sure that we feel comfortable treating it and removing the disease. And so when we're looking at these different areas of endometriosis, it's important to feel comfortable excising the endometriosis, not just burning or cauterizing. And this is other questions to ask your doctor. Do you feel comfortable removing this around my nerves? Do you feel comfortable removing this around the colon or the rectum? What do you do if it's on the ureter, which is the tube that carries urine from the kidney to the bladder? How about my bladder? How do you feel comfortable doing that? Are you going to preserve my fertility? Is that, if that's something that's important to you? What do you do if it's on the ovary? What do you do, in all these different areas? It's imperative to make sure you get these answers to surgery ahead of time. And if your doctor doesn't necessarily feel comfortable with that, you need to make sure that you feel comfortable with that moving forward with surgery, because excision surgery gives significantly better outcomes, both for pain response and for fertility. But it is a slightly difficult, more difficult surgical technique. Sometimes it's significantly more difficult. It kind of depends on the patient, but it's really important to make sure that you have someone that feels safe removing the disease from all these areas. And then, like I mentioned, most importantly, identifying these areas. So one, identifying them, and two, making sure that it's removed safely. Okay, so this person said they had suspected endo, but was treated with birth control, but they didn't want to do surgery because it wasn't considered severe enough. That's frustrating for me, because what is more severe? Is it a quality of life issue? If you have endometriosis, it's affecting your daily functioning. And birth control does not necessarily make the endometriosis stop. It may slow the progression, but it may not. And the longer we let the endometriosis grow and progress, the longer, the more long-term sequela we have, the more likely it is that it will affect your fertility. More likely it is that your pain and your nerves are damaged to the point where it's difficult to reverse some of that long-term damage. And so one of the goals of my career is to try to treat women earlier, try to move that curve of people taking 5 to 7 years to get a diagnosis with laparoscopy and then essentially endometriosis excision. Because the earlier we treat the disease, the earlier we go in and excise the endometriosis and remove it from all these different areas, the better long-term outcomes we have, because it's a better chance that endometriosis doesn't recur. If we can catch endo at a stage 1, stage 2, it's very different than when we're having surgery on a stage 4. So if you just wait until it's severe enough, well, it's not good medicine, because as the endometriosis grows and gets worse, it has a higher risk of recurring, higher risk of damaging to the other organ structures, and then higher chances of it negatively affecting your fertility. The caveat to that, though, is who is going to become stage 4? Which patients are going to become, have worse endometriosis where you can't, your risk of recurrence is a lot higher. And that we don't know. But the earlier we treat the endometriosis, the better our outcomes are. And I think that has been well studied. And in the fertility literature, knowing that as endometriosis is excised, you have better chances of fertility, but it also is decreasing that inflammation, in the pelvis. Burning or cauterizing the endo, or just having a laparoscopy where they go in and take a look, but they don't take samples, really is not beneficial. So it's imperative to make sure that you advocate for yourself, but know that severity is difficult to anticipate because we can't really see it on imaging. How do we know if it's growing or getting worse? A lot of that is your symptoms and symptomatology. And birth control is not wrong. A lot of times it does help people with their symptoms, but requiring you to wait because it's not severe enough, I think I would have a different approach to that. And it is important to know your body and decide what you feel is best, obviously. Okay, so I got off on a tangent a little bit, so I apologize there, but I'm going to go back a little bit to the webinar. So we started with your test came back normal, so why do you still feel like this? If everything is normal on the imaging, why don't you feel that way? But we talked about how endometriosis frequently doesn't show up on standard imaging until it's more advanced. And so this is what's called the test blind spot. So, and this is one of the biggest reasons conditions like endometriosis go unrecognized early because we don't see anything tangible and it's not being detected the way that people expect. And so it is very difficult. For example, if you have right lower quadrant pain, you have a CT scan that shows appendicitis, we're going surgically remove the appendix, we know you're going to feel better. That's something tangible. We see it on imaging. We have a high suspicion for where it is, but we see it and we go and take care of it. Endometriosis is not that way. Unless you have an endometrioma, a large cyst, deep infiltrating endometriosis into the colon, or deep infiltrating endometriosis elsewhere, which sometimes it still doesn't pick up. So more advanced stage 3 or stage 4, most of the time your imaging is quote normal, even with pretty significant ultrasound mapping, MRIs. Most of the time it's not seen, and so we go based more on your symptoms. So I wanted to, discuss that normal tests do not equal normal body. Normal results do not always mean that nothing's wrong. And I think that that is really important. Symptoms like pain, bloating, fatigue, bowel symptoms, bladder symptoms, those should be addressed. And so the next thing we talk about is how your symptoms are data. And then understanding the pattern. So really listening to your symptoms and how they're affecting your body, and then trying to pick up different patterns. Is this worse around your cycle? Do you notice these symptoms around ovulation? How about the week after your cycle? Classically, women with endometriosis have painful periods. Some women from a very young age. As the endometriosis grows, you start to have pain outside of your period. So pain with ovulation, the pain the week before your cycle, pain that, radiating, pain that's affecting your bowels, constipation, diarrhea, pain with bowel movement, bladder symptoms, painful intercourse, and the list goes on. As it starts to grow, it starts to affect other organ systems. And this is because it's not just a pelvic disease of the reproductive organs. This is very much a whole body inflammatory disease. And so listening to these data points and trying to pick out the patterns certainly will help you. And if you listen to these patterns and you listen to your body, that's when you're going to be able to pick up endometriosis. When I see a patient in the office, all I do is listen. It's actually not that hard. I ask them some of these different questions, but a lot of times I'm just listening to their health history. I'm listening to their stories, listening to how their bodies have changed, listening to how their symptoms have changed. And most of the time, we can come to this agreement that endometriosis is more likely. Most women don't come see me because they're feeling good. They come when they're starting to have more symptoms. And so it's important to make sure that you're really listening to their history, because of course, sometimes we get imaging, ultrasounds, MRIs, but a lot of times it is we diagnose endometriosis based on their symptoms. And so it's really important to listen to these patterns and these data points. So the next thing I want to talk about is why you were dismissed. So this is the hardest part for most women. You did everything right. You got checked. You asked the questions. But the system relies on tests, and that's when tests don't show anything. So their symptoms get minimized. So you're left thinking, well, maybe it's just me. Maybe this is normal. But it's not about you, and you're not overreacting. It's something is being missed. And that's when, you really have to advocate for yourself. If you know that there's something that's not right, your body doesn't feel normal, the inflammation is significant, it's getting worse with time. You've been trying for pregnancy for over a year or 6 months if you're, over 35 and you're not being successful. If you're starting to have, worsening changes in your bowel habits, the fatigue and the bloating are so significant, it's difficult to function. That's when you need to ask for more. see a specialist, talk to somebody else that understands that these lab tests are not just what we're looking at. It is more of a whole body approach. And I do think that endometriosis should be treated holistically, because as it is not just a pelvic disease, it affects these different organs, making sure that we're attacking it from all angles. And I talk about this with my patients. Diet, finding foods that are more inflammatory. A recent study showed up to 70% of women with endometriosis had some sort of gluten intolerance. Now, it doesn't mean celiac disease, but some sort of, inflammation related to gluten. And gluten tends to be more inflammatory anyways. Women with endometriosis have a baseline inflammation, so it doesn't take much to kind of tip them over the edge. Sometimes it's dairy, sometimes it's particular food groups. I like whole foods diet, which is fruits, veggies, and lean meats. That then you can kind of like add or subtract foods as you feel like you can, to see what your body can tolerate, see which foods maybe cause you to have more flaring. Next, we talk about acupuncture. Acupuncture is one thing that is not Western medicine, but does have some good evidence behind it. Which is using acupuncture to help with kind of down regulation of some of that central sensitization of pain. We talk about exercise, having some of that steroid surge, those hormones that make you feel happy and like the happy hormones, some of those transition to steroids, and steroids are truly anti-inflammatory. In my practice, we do always talk about hormones. We talk about progesterones, traditional birth controls, IUDs. They're not wrong. Not every patient wants to try them or use them, and that's completely fine. I just want to make sure that my patients understand all of their options. And then lastly, we talk about surgery. Surgery is the gold standard of treatment. Not only is a diagnosis, so a diagnostic, so you get a diagnosis, but it's also therapeutic in that removing the endometriosis at its root cause is going to give you your best outcome. The earlier we can treat the endometriosis with thorough excision is going to give you better outcomes for fertility, for chronic pain, for letting the tissues remodel with healthy tissue in that area. And it's very important to understand that sometimes when you're doing all the less invasive measures, if you don't get to the root cause, you may not see a benefit because of how your body is still responding to these cells. Okay. I'm going to go to the chat and answer a few more questions before going back to the webinar. All right, let's see. Remember, in the chat, there is a link to schedule a visit with my staff. Her name is Cyrus. So this is not a visit directly with me, but a visit with my office manager. She'll be able to go over surgery or visit scheduling so you can get a spot with me. She'll go over insurance, dates that are available for surgery, kind of walk you through the scheduling process. But this link in the calendar, or the link in the chat is a calendar link to meet with her and talk about seeing if you want to schedule a visit with us at Endometriosis Center of Excellence. Okay, let's answer a few more questions. What is the recurrence rate after hysterectomy? How do you determine if endo is affecting nerves? So hysterectomy does not treat endometriosis. And that's something we've talked about in our other webinars. Hysterectomy can treat what they call adenomyosis, which is uterine inflammation. But theoretically, the diagnosis of endometriosis is that these cells are outside of the uterus. They are outside of the uterus where they're not supposed to be. We don't know exactly why. My theory is that they don't migrate where they're supposed to, even when you're being formed. Then they start to grow with estrogen when your body starts having cycles. The most important part about surgery is removing the endometriosis cells, not just the hysterectomy. An excision surgery is the only way to remove the endometriosis. Now, the hysterectomy is a cure for adenomyosis, the uterine inflammation, so that is a benefit. But without excision surgery, in addition to the hysterectomy, essentially the endometriosis cells were not treated. Recurrence rates change based on stage. So this is statistics over all excision surgeons or endometriosis specialists. This is not the same for if you're not doing like aggressive excision surgery. But for lower stage disease, stage 1 or stage 2, your risk of recurrence is about 10 to 15% at 5 years. Some early stage 3 is also that way. When you have an endometrioma, which is a cyst on your ovary filled with endometriosis, your risk of recurrence goes up pretty significantly, up to 30%. And this is because every time you ovulate, your ovary may grab some microscopic cells of endometriosis and ultimately form another endometrioma. And so your risk of recurrence goes up. The only medication we have that may decrease endometrioma or cyst formation is medications that prevent ovulation, which is birth control pills or high-dose progesterones. And unfortunately, outside of that, we don't have any other medication that has been shown to decrease recurrent cysts. And so sometimes after surgery, if a patient has an endometrioma, we at least talk about, some of those options so that she can decide what's best for her. Some of the patients choose to go on suppression, ovarian suppression, to try to prevent endometriomas from recurring. Other patients really don't feel comfortable with that, or if they've had side effects from the medication. But ultimately, it's very individualized treatment. So hysterectomy is treating adenomyosis. Endometriosis excision is treating the endometriosis. And if you didn't have excision with your hysterectomy, well, then the endometriosis is likely still present. But that's something you'll have to talk to your surgeon about or look into your pathology report. Okay, going back to the webinar a little bit. So we're talking about why testing does not show endometriosis frequently until endometriosis is more advanced. We talked about how it delays diagnosis for endometriosis, this test blind spot, so that endometriosis is going unrecognized. You start to feel defeated because you're like, if my tests are normal, I must be fine. But remember that normal results does not always mean that nothing is wrong. You really have to listen to your body, listen to the symptoms, use these data points and these patterns to help get a clear explanation of what's going on. Use these patterns and data points to talk to your doctor about endometriosis, why these symptoms, are getting worse over time, how they're happening throughout your cycle. So the patterns are where you start to see endometriosis first. And like I mentioned, it's identified in the history, identified in talking to your patients, not usually with imaging. And sometimes it is, but most of the time it's diagnosed based on just talking and listening. And so when you're thinking, well, if my test is fine, maybe it's just me, or maybe this is just normal, but you're not overreacting. This is telling you that something's being missed. So here's what I want you to take away. If your tests are normal, but your body does not feel normal, that matters. If something feels off, that matters. And if you've been looking for answers, you're not alone. So that's exactly why we offer this private clarity consultations, because most women don't need more tests. They need a better understanding of their symptoms. On this visit in my office, rather telehealth or in person, we walk you through your symptoms in detail, identify what may have been overlooked, help you understand if your patterns align with endometriosis, and then map out your next best steps. We only offer a limited number of these consultations each month. So when spots fill, we close the calendar. If you've been told everything is normal, but it doesn't feel like that, this is your next step. So imagine finally understanding why your tests didn't match your symptoms, what your body has been trying to tell you, and what to do next. No more confusion, no more dismissal, just clarity. And that's what we try to provide at Endometriosis Center of Excellence. We focus, primarily and specifically on endometriosis affecting fertility, chronic pain. Like I mentioned, right now we are booked out really until the beginning of the year. However, we are bringing on another surgeon at the beginning of the year. So I'm hoping that we will be able to decrease that wait time and get patients in for surgical treatment earlier, as well as initial visits. And so when that opens up for scheduling visits, I certainly will let you know. I'm going to pop back to the chat and answer some more questions. Thank you guys for being interactive today, so I don't have to just talk to myself the whole time. I could talk about endometriosis for hours. I'm very passionate about this. I see how it affects women. I see my patients are strong and they are incredible people. It's really amazing to watch what they've overcome, with the amount of pain that they have, with the amount of disease that's present. It's incredible. I have learned perseverance from my patients. I've seen their strength. And this is a disease that unfortunately affects a lot of women. 1 in 10 women are affected with endometriosis. And the diagnosis and the treatment is not that difficult. You just have to listen to your patients and understand the disease to understand what the symptoms, how the different symptoms present. Okay. Let's see. I'm going to go through and add, let's see. So somebody said, can endometriosis come back even if you had good excision? You can. It depends on how the technique and that they use to remove the endometriosis. If it was truly excision with retroperitoneal dissection. Let's see. Does your clinic treat the issues associated with suppression? Hormone suppression causes menopausal type symptoms, how to manage that. So we are a surgical practice. Our goal is to have patients come in, go through a treatment plan that includes lifestyle changes, a holistic approach, surgery to get rid of the root cause. And then we follow you for a few months after surgery. And then ultimately the goal is to set you up for success so that you can be kind of given to your local OBGYN, your local PCP, somebody that can help you with long-term management. We usually don't use suppressive medications. Sometimes we do, like if patients come in on Lupron or Myfembry or Alyssa, we usually don't stop them cold turkey. But whoever prescribed them can sort of help manage your symptoms. Now, after surgery, if your ovaries were removed, for example, we do start hormone replacement therapy right away and try to help manage that to get to a good spot where you're having some steady state hormones before passing you off to like a local doctor. But we do try to help kind of optimize that for you. So while you're in our treatment plan, of course, we will help manage some of these symptoms, but we don't do medical management of endometriosis long term. But we certainly help you in the short term with a holistic approach, diet, exercise, physical therapy, surgery, and that immediate post-op period to make sure that we're trying to set you up for success. Let's see. People say, what are the different mapping types? How can you map endometriosis? So there's a few different ways. Some people do ultrasound mapping. That's with a comprehensive pelvic ultrasound. Sometimes they use vaginal dye. It's a prolonged ultrasound. Sometimes we use MRIs. That's usually my preference. CT scans don't show the soft tissues as well. So usually surgical mapping is done rather with MRI or complex ultrasounds. And I think different providers have different ways that they evaluate that. Some people get an MRI and a colonoscopy on everybody before they have surgery. Some people have ultrasound mapping for every patient. Some people have an MRI for every patient. I'm somewhere in the middle. I listen to my patients. I look at their other imaging that they've had, rather traditional ultrasound or CT scan, listen to their symptoms, decide if imaging we decide together if imaging would change an outcome or help with surgical planning. And sometimes it would. Sometimes it's hard to know. MRIs, many times are helpful, but many times you also have a normal or negative MRI, which does not rule out endometriosis. It may rule out deep infiltrating disease of the rectum, decrease your risk of needing a like low anterior resection or a section of the colon removed, but it doesn't necessarily rule out your risk of endometriosis or the chances that endometriosis is present. Okay, Kaylee said, do you see any recurring connections with endo to POTS, MCAS, and connective tissue disease? Absolutely. Today, I had two MCAS patients already. Probably a third of my patients have hypermobile EDS. There's a strong correlation with these other comorbidities. And again, it's not necessarily causative. Like endometriosis doesn't necessarily cause EDS or cause MCAS, and vice versa, but it's very common to have these comorbidities, similar to interstitial cystitis or bladder pain, IBS. These symptoms can certainly be common together as well as these diagnoses. And so it is important to make sure that your surgical team as well as your clinic staff understand these diagnoses and how to help manage them in the post-op period. Women with POTS sometimes have trouble with regulation after surgery and in their blood pressure. Some people with MCAS have more inflammatory response. Some people depending on what the diagnosis is, but it's really important to make sure that we're being thorough in this evaluation, but also thorough with our other diagnoses so that we can make sure that these other comorbidities are kind of being managed as best they can as well. That's a good question. So MCAS, POTS, EDS, those are all very common to be diagnosed together. Okay, I'm going to go to a few more questions in the chat. Again, remember there's a link there that you can click on to have a meeting with my surgery scheduler, Cyrus. She'll be able to walk you through clinic scheduling, your insurance, finding a spot to meet with me. We do try to give people on the webinar some priority, but I will warn you, we're pretty booked out. But we're working on that with our new surgeon that's going to come in January. Okay, this says, can you have fibroids, adeno, and endometriosis? Yes. Yes, you can. Unfortunately, not one is exclusive of the other. Can these issues overlap and kind of mask the endometriosis? They can. And sometimes it's hard to tease out exactly which symptoms are related to adenomyosis, which symptoms are related to endometriosis. They certainly have some overlap there. And that's why the history taking is very helpful. Is it mostly heavy bleeding? That may be more fibroids or adenomyosis, or is that when your pain is exacerbated? Is it pain outside of your cycle, bowel symptoms, pain with intercourse? That may be more endometriosis, but it's hard to know. That's why it's really important to really do a deep dive into your symptoms. This is not an algorithm. Women with endometriosis, this is not a one size fits all. Every person is different. Their symptoms are different. The way they respond to medications, the way they respond to surgery is individualized. And so it's important to understand that when you're coming up with a treatment plan, because it is not a one size fits all. And understanding how it all works together, how the body is responding to the inflammation from foods, from the lack of exercise, how the muscles and the nerves play a part in this with pelvic floor tension and pelvic floor dysfunction, making sure you have a physical therapist on board. If that's not improving, seeing if you need to do nerve injections or have a physiatrist help you, somebody that's helping with kind of the central sensitization of pain and management in that regard. But it is it's important to listen, because really listening and getting the history is going to give us our most information. And imaging is helpful, especially with fibroids. That's one thing we can see on imaging, but really just working through your different options so that you understand what's best for you. Okay. This person said, can you speak the difference on robotic surgery versus traditional laparoscopy? Ultimately, it depends on the surgeon and the tools that they choose to treat endometriosis. Most of my surgeries are done robotically. I do some laparoscopically. It's very important that your doctor feels comfortable doing excision surgery laparoscopically. Are you going to remove disease from the bowel, from the bladder, from the nerves, from the ligaments, from the ureters? The robot does give some a more precise dissection. So my more difficult surgeries, I strongly desire to use the robot just because it has better visualization and better dexterity in my instruments. But I do some laparoscopy, and I do feel comfortable doing that, but just making sure that the endometriosis is fully excised on all these areas. And so if that's the tool that your doctor chooses to use, just make sure you're asking them about where they can remove endometriosis and maybe where they can't. And so that way you kind of know what you're getting before going into surgery. All right, let's see. Um, all right, this is interesting. What is the youngest or oldest age patient that you've seen? My youngest patient has been 14. And then my oldest patient is in her 60s. Most endometriosis, though, is, late teens, early 20s. My fertility patients tend to be in their 30s because the endometriosis is just kind of sat there and kind of, grown over time. Sometimes it's silent endometriosis, which can be much more difficult because it's a catch-22. It's a blessing that you don't have pain, but because you haven't had symptoms from the endometriosis has continued to grow and therefore affecting their fertility down the road. But it's a pretty wide range. So 14 to in the 60s, but most of my patients are ages 18 to 30. If I had, that's where most of my patients land. I do have some fertility patients that are older than 30, but usually that's where they are. And my goal is to try to treat patients younger, try to catch endometriosis early, treat the disease with good excision surgery so there's better chance that it doesn't affect their fertility down the road, that their body can start to heal, the tissues remodel, which can take up to a year after surgery, and just letting their bodies heal without the underlying cells there so that hopefully some of that inflammation goes down. Endometriosis, of course, can still recur, but the earlier you treat it, the less likely that is. And so I'm a big advocate of trying to treat people earlier rather than later. And medications are not wrong, but if you try medications and they're not working, you absolutely should move towards next steps, which would be endometriosis excision surgery to make sure that the endometriosis isn't, progressing, and we try to catch it at an early time. So thank you guys for meeting with me. It is always such an honor to meet and talk about endometriosis, try to advocate for my patients and endometriosis awareness. I'm in Dallas, Texas at Endometriosis Center of Excellence. I feel very passionate about endometriosis. I could talk here for hours about endo. You give me a topic, I can go on about it. But I think really what I wanted to bring home today is that just because your imaging and your tests are normal does not rule out endometriosis. It is not, and it should not dissuade you from continuing to get treatment and to get answers. Many times endometriosis is not seen on imaging or abnormal labs. And so that's why we have to diagnose based on symptoms and your history. And just listening to patients most of the time is going to give you that answer. And of course, there's some complexities there, but it's imperative to listen to your body and try to understand what's going on. So if you would like to schedule a visit with me, you can click the link to meet with my office manager, Cyrus. She will be able to go over dates that are available to schedule your insurance. Like I mentioned, it's very exciting, but we will have a surgeon joining us in January as well. So hopefully once she gets started, we'll be able to decrease that wait time. But I hope you'll have a good rest of your week. Happy Wednesday. And I look forward to meeting with some of y'all again, rather in person, telehealth, or maybe at my next webinar. Hope you'll have a good rest of your day.